Diabetes burnout does not only affect mood, it can quietly change treatment choices, follow-up behavior, and whether a plan remains realistic enough to keep working. People often talk about diabetes burnout as if it were just frustration. It is usually more than that. Burnout changes attention, motivation, self-talk, and how much decision-making energy a person has left for food, monitoring, medication, and follow-up. When burnout builds, treatment does not fail only because the body is difficult. It can fail because the plan has become emotionally too heavy to carry in its current form. Understanding that matters, because a person who feels ashamed about burnout may hide it, and hidden burnout quietly distorts care. Burnout does not always look dramatic. Sometimes it looks like avoiding the glucose meter because every number feels like a verdict. Sometimes it looks like missing refills, postponing labs, skipping meals, and then overeating, or tuning out every new suggestion because the whole topic feels exhausting. The outside behavior may look like laziness or indifference. The internal reality is often overload. That difference matters because a plan built for a fully energized person may collapse when someone is already depleted. Imagine someone who knows what they are supposed to do, but feels dread every time diabetes comes up. Their numbers worsen, and they assume the only solution is to try harder. A better frame might be different. Are they confused about the treatment target? Are medication effects unclear? Are cost and side effects draining commitment? Has the routine become too complicated for their current life? Burnout changes the meaning of non-adherence. It can point to a plan that needs redesign, not just more pressure. One common mistake is moralizing the whole problem. A bad week becomes proof of weakness. A missed refill becomes proof that the person does not care. That mindset makes burnout worse because shame is cognitively expensive. Another mistake is pretending burnout is separate from medical care. If discouragement is changing whether someone takes medication, checks glucose, eats consistently, or shows up for follow-up, then burnout is already part of treatment. It belongs in the clinical conversation. From a systems standpoint, the next step is to make the picture easier to act on. Review the trend in labs, symptoms, treatment questions, and follow-up decisions so the system is understandable, not mysterious. If diabetes burnout feels real, name it directly. Ask which part of the plan has the highest return for the least friction right now. Ask whether the routine can be simplified. Ask what metric matters most over the next few weeks, so everything does not feel equally urgent. Track trends instead of punishing yourself with single readings. And if emotional strain is driving avoidance, bring that into the visit as a treatment problem that needs solving. Diabetes burnout matters because treatment is not only biochemical. It is also behavioral, cognitive, and emotional. A plan works better when it matches what a person can realistically sustain, not only what looks ideal on paper. If this helped you name a part of diabetes treatment that often gets ignored, subscribe to the Metabolic Keys and comment with the routine or decision that feels hardest to carry right now. If this made the topic clearer, like the video, subscribe to the Metabolic Keys, and comment with the treatment, question, or interpretation you think matters most for real-life decision-making.